Welcome to Slide Review. So today we are going to finish off our GI chapter going into some of the malignant colon and appendiceal lesions. So for our first year that's in the audience, I really hope you were paying attention today during our faculty lecture. That's your hint.
And I have a specimen that I'm going to grow, and it's the same thing.
There you go. As always, we start with our standard disclaimer. Any questions, comments, concerns, conundrums, etc., please put them in the comments below. We always have both our hashtags for, or our handles, I guess, for Twitter below, and we're going to go relatively quick since we got a late start today, and that is totally on me because I was testing mics. So we are going to start with the appendix. Premalignant and malignant lesions. Well, spoiler alert, everything today pretty much is premalignant, malignant lesions. There may be one or two surprises in there. And this is case 1.
Tubular adenoma.
Wow, okay, tubular adenoma from like 1X view on an appendix. Could be. But the first thing we notice is that there's a lot going on, right?
Yeah.
Yeah. So do we even know that we're in appendix? Well, I'm telling you, so that's one thing, but how about we go a little higher power? Okay, so what kind of epithelium would we expect to see in the appendix?
Columnar.
Columnar, right. So we have all this beautiful columnar epithelium. Some of it has more mucin than others. And there's a lot of it on this slide, so we're not going to spend too much time on this, but this is beautiful. It's pseudostratified in some areas. I don't think there's any overt dysplasia per se. There might be some focal stuff. But this is really the area of interest. So if we go back to low power, you can kind of see that there's an expansion here, but don't beat yourself up if you're going, well, it's really pink and I'm just going to kind of gloss over it. But this is really the area of interest. So how does this look different from what we saw on the epithelial surface?
This looks lighter.
It looks lighter, yeah.
Seems mucinous.
Seems mucinous, I like all that. How about the nuclei?
They're kind of flattened.
They're kind of flattened, yeah. And they're all pushed towards the base.
The base, yeah.
And they're just these big fat cells. But we're not ready to call them signet ring, right? These are not signet ring cells. But they are very, very plump. They are filled with mucin. And they just kind of are in this weird background where it doesn't quite belong. We do have, we love people coming in. This is great. So for anyone joining, I can't hear you, so make sure you're typing in the chat box so that we know if you have any questions or comments. And yeah, so we're looking at a bunch of mucinous stuff. If I could maybe pop up with a little anecdote, I would say that maybe these are somewhat cup shaped, maybe like a wine goblet.
So this is metaplasia?
Oh, well, this goes beyond metaplasia. So metaplasia is something that should occur within a normal structure, but that is an excellent point.
Normal, yeah, this is intestine.
Right. So this looks invasive, right? Because it's nowhere near anything normal. So when we have invasive, what do we call it? I know you saw one of these today during the faculty lecture. So.
Oh, yeah. A mucinous, invasive mucinous neoplasm?
Okay, you're most of the way there, so I'll give it to you. So because these are goblet cells, this is actually a goblet cell adenocarcinoma. This used to just be called goblet cell carcinoma. And really this is the main feature that you're looking for, is just these little islands of goblet cells that are just kind of percolating through everything. You can have background dysplasia. Actually, this kind of looks dysplastic. It's way too blue. This is more just piquing my curiosity. Yeah, a little bit. But regardless of what's happening on the epithelial surface, this is your main feature in this case, which is why I liked it, because I thought it wasn't very difficult to find it on the case. And this is the best spot. But you could go around and see if there's other areas, and there very likely are. But again, just for the interest of time. These can be really sneaky, so sometimes you might think, oh, maybe I have goblet cells or signet ring cells, and it's actually fat or lymphatics, so that's when your stains really help you. And speaking of stains, we have a helpful dot, which is always nice, and this is actually the same case, so if we rotate it, so you can see exact same orientation. So this was the area we were looking at, and our helpful dot lets us know, but for IHC, you kind of have to scan at high power anyway, and this is a synaptophysin stain. So what we notice is it's staining all the goblet cells, well, most of them. And there is a little bit of staining within your regular columnar epithelium, but that's also to be expected because you do have neuroendocrine cells normally within your GI tract. One of the things I like to point out in med school is that your GI tract actually produces more serotonin than your brain. So, okay, I've talked enough about the cells, about the slides. So goblet cell adenocarcinoma, this is extremely rare. Thankfully, it has a whole bunch of old names. We don't use any of these names, so they're up there just so that if you see them on an old report, you're not going, what the heck are they talking about? This occurs in adults, and again, it will occur in adults that are older than your conventional neuroendocrine tumor. This is what NET stands for, neuroendocrine tumor. And if there's any presentation, they might look like they have acute appendicitis or even perforation. Again, this occurs predominantly in the appendix, but you can see it in other areas of the GI tract. Grossly, you're going to have either diffuse wall thickening, you can have dilatation of your appendiceal lumen with mucin. So hopefully at this point you can really appreciate how it would be difficult grossly to say, am I looking at a goblet cell adenocarcinoma? Am I looking at an appendiceal mucinous neoplasm? And with all these things, we submit the appendix entirely. So you want to make sure that you're looking at your proximal margin, your distal tip should be bisected, and you serially submit the remainder. But all these nice, beautiful goblet cells. Microscopically, you can have mucosal surface involvement, which again, I didn't really necessarily appreciate mucosal surface involvement in this case. However, there you go. Immediately overlying the tumor, you shouldn't have no dysplasia. It looked like we had some dysplasia over on the one side, but that wasn't in the area that was overlying the goblet cells, so that's probably still okay. As we saw, the goblet cells are in these really small nests and islands, and they kind of can be swimming in mucin at the same time. Obviously, they are filled with mucin as well. So they kind of give the appearance of signet rings, but that nucleus is still a little more plump, and they're sometimes not as rounded. Sometimes they're more elongated. They can also fool you by sometimes looking like they have lumen formation, so that's really where the adenocarcinoma part somewhat comes from. Again, this thing has had so many names over the years that there's been a lot of debates in many different venues regarding that. And just like our signet rings, these can present as single cells, just to terrify you even more. You can see past cell metaplasia, your ECC cell-like metaplasia, and what'll happen is that it tries to look like normal crypt architecture. So instead of just having goblet cells around, it's going to try and recapitulate what a normal crypt should look like. Often your glands are going to be within the deep mucosa, and they kind of almost like to form like an onion skinning or like concentric layers around the appendiceal lumen itself. That wasn't really able to be appreciated in the sections that we had because they were more like cross sections through the side of the appendix rather than through like an entire ring of the appendix. And that might also be owing to how thick the appendiceal wall was. We saw mucin pools, but you don't always have to see them, and really it should be bland. Again, you shouldn't have diffuse signet ring morphology. You can have focal stuff, like, okay, maybe this guy looks kind of like a signet ring and this guy does, but these guys don't. They kind of look more polyhedral. This one definitely doesn't, because it's not the right shape and the nucleus is too large. And then your aggressive behavior is pretty much all the things that we would expect to see in other poorly differentiated carcinomas, which would be your signet rings, lymphovascular invasion, that's your LVI, and a really high mitotic index. So high mitotic index for these is greater than 20 mitotic figures per high power field. And your stains, well, you have a lot of stains to look for. Mucicarmine would stain the cytoplasmic mucin as well as any mucin pools. These are keratin positive, and there's a whole bunch of other stains that you can use. Chromogranin and synaptophysin, even though synaptophysin was the stain of choice that they used, these aren't stains that you would have to use for diagnosis, okay? The molecular is also different from a lot of other GI tract malignancies. So we're looking at things like our iridia, ARID2, CDH1. So remember, this is your E-cadherin, all right, also associated with things in the stomach, and lobular breast carcinoma, because you know I'm going to go back to breast cancer sooner or later in a lecture, right? But you don't really see the KRAS, BRAF, beta-catenin, SMAD4, so all those kind of mutations that we're used to seeing in other GI things, we don't really see here. And then there's also been reports of loss of heterozygosity, that's your LOH, in 11q, 16q, and 18q. And your differential is pretty much things that either look like neuroendocrine or things that are clear, and other lesions that like to occur within the appendix. So they can do an appendectomy for it, but some people argue that you really should be doing a hemicolectomy. And some people will say that you should really tag on some chemotherapy with these. But really, the 5-year survival is excellent with these at 75 to 85%. And they're somewhere in between a low-grade adenocarcinoma and a neuroendocrine tumor within the appendix. So they're somewhere in between there. So that, because of the similarity in behavior to the low-grade adenocarcinoma, that's why people would argue for the right hemicolectomy. Okay, but goblet cell adenocarcinoma, another rare entity, and one that I think is really recognizable as soon as you see it. This is case 2. So at low power, the most prominent feature is
the blueness of the epithelium.
the blueness of the epithelium. Okay, definitely, it is blue. I like that. What about all this stuff? Any idea what this might be?
No.
I have something in the chat. A low power diagnosis, yes. Well, maybe. We're getting there. It does pop up, I like that, okay. So to me, well, okay, it's kind of unfair for me to say, to me, this looks like this, because I know what these are, since I put the slide decks together. But this is mucin pools. Okay, so the appendix is somewhat dilated, not terribly, but it is dilated with and filled with this mucin. Whereas maybe it's not as appreciable here and here. Like this looks more normal, even though there's maybe some blood going on. Anyway, we're looking at malignancy and pre-malignancy within the appendix, so this is probably what we want to look at. And if we go in we see what type of epithelium right away.
Columnar.
Columnar, yes. And all these beautiful goblet cells. So this is what goblet cells look like normally. So hopefully, like, see, there's still some really round goblet cells in here. But this case is just really nice for showing that. There are areas within this section that are less mucinous. But then we start seeing stuff like this. All this irregularity. It's almost like a sawtooth. So this is what we refer to, even though I know, granted, this is not the best example. Again, here, some of that sawtooth irregularity. So this is what we refer to as, like, okay, we're looking at maybe serrated areas, and we have all this mucinous stuff going on. So at this point, you know, you're looking at, do I have maybe a lamin or a low-grade appendiceal mucinous neoplasm, or does this not have neoplasia, and are we more in like the mucinous cyst adenoma type realm? And really, there isn't dysplasia in this case. Everything's pretty well lined up, but it has this relatively prominent serrated appearance and lots of mucin. Okay? And you can go all the way around with this, and it kind of looks the same. If you want to go into these areas, you have all this sloughing off where it wasn't really happy. Maybe it took a little bit before it was put into formalin, but this is all normal. And here we start seeing a little more of the mucinous face. Oh, there it is, coming down here. But really, it's the cross-section of the tip that gives you the best view of that. So what we're looking at here is a mucinous cystadenoma. So all within this family, and I can't spell, so I'm going to have to fix that. But we can see how there's all these different names for an amin, or appendiceal mucinous neoplasm, since this one doesn't really have dysplasia. These are uncommon, and lamins, or low grade, tends to occur in 1 in 100,000, whereas appendiceal adenocarcinoma is in 0.2 per 100,000 per year. And the stats, whenever I present them, those are almost always exclusive to the United States. They have a wide range of adults that they will affect. So saying 20 to 70 years old are most common. It's like saying, well, if you're an adult, it's most likely to affect you. It does happen in females more than males, and most often these patients are asymptomatic. They aren't aware that anything's going on, but they might have a picture that looks like acute appendicitis, or peritonitis if they do have rupture or dissemination of the lesion. Again, this occurs within the appendix, and grossly you'll see that dilated lumen, but be aware that it can appear normal. So you might not have obvious mucin, it might not be dilated. You must examine for perforation, and why? Well, if you have like your high-grade lesions and even your low-grade lesions, you want to make sure that you're not looking at disseminated disease. So your biggest hints that there isn't a perforation is that your serosa is going to be smooth and glistening. Okay, it's not going to be erythematous and dull, and you won't have any adhesions or obvious mucin on the outside of the wall. So this is showing beautiful views between our mucin pools, and here you have some dysplastic epithelium. And here what we're showing is what's sometimes referred to as epithelial displacement. So pretty much you get like diverticular formation, and we have epithelium that's over here.
So the picture above, would that be lamin then?
On this side, yes.
Yeah.
But yeah, there are tricks to everything to determine if something is invasive or not.
Mm-hmm.
So microscopically, your cells are going to be relatively benign looking, okay? Like what we saw, they were very tall, they had those thin mucin vacuoles, so they almost looked like champagne flutes. Your nuclei are going to be at the base. And what happens is that in dysplastic situations, because there's so much mucin, it can actually flatten out your epithelium, so it will actually look like you really don't have much of anything, and that's why examining your epithelium and the entire section is so important. So obviously if this is happening, you're not going to see that beautiful serrated architecture. We were able to appreciate that in ours, and you may or may not have dysplasia, similar to your serrated, your sessile serrated lesions. And you can have epithelial displacement or diverticula. Again, this is relatively common, and you have to imagine that there's so much mucin being produced by the epithelium that it's pushing on the wall of the appendix, and eventually just you get these diverticula, these outpouchings through the muscularis mucosae and muscularis propria, to where you pretty much just have epithelium sitting out in like the submucosal and serosal soft tissue on its own. And obviously those are a perforation risk. For your lamins, they may or may not have dissemination, okay, so that's why, again, looking for perforation is so important. Your mucin should still be at the apical surface, so on top of the nuclei, but your nuclei are going to become very hyperchromatic, and they'll still have inconspicuous nucleoli. And inconspicuous means that you shouldn't really appreciate nucleoli even at high power. Now, if you're scanning at 40x or 60x and you're thinking, well, I can see some nucleoli, you probably should see them anyway, but you shouldn't really be picking them out at 20x or 10x. That's what it means by inconspicuous. For your high-grade dysplasia without invasion, right, because invasive would make it adenocarcinoma, what happens is you get an increased nuclear to cytoplasmic ratio, okay? So your nuclei are becoming larger, loss of nuclear polarity, so instead of being at the base of the cell, they are going to start traveling up, and you might see mucin more towards the base, or the nucleus might be in the middle of the cell. And speaking of mucin, it will be decreased, and you may or may not start seeing signet ring cells. So again, hopefully this is where you can appreciate, going back to our previous case, trying to compare lamins and Hammonds to your goblet cell adenocarcinoma, as well as signet ring adenocarcinoma. You may or may not see cribriform or back-to-back patterns as well. And then our mucinous adenocarcinomas, pretty much you have your high-grade dysplasia and there's clear invasion. So it's not this kind of picture where you have a diverticula and maybe this is just a weird cut. You're going to see it sprinkled all the way through. Positive stains, so like any mucinous thing, CDX2 is going to be positive. Like our lower GI, CK20 and SATB2 will be positive. Negative stains, PAX8, and that's really important in your female patients because that's your differentiation from ovarian lesions. Molecular, KRAS and GNAS, so those are your big players on this. You can see loss of heterozygosity with 5q as well as 18q, so that's looking at your APC and SMAD4 genes. These lesions themselves are microsatellite stable and they do not have BRAF mutations. So I don't know for anyone else out there that maybe has a difficult time remembering all these translocations and all the different genes, but BRAF is a pretty good go-to for most things, but it's not in this. So that's one of the things to take care of and take it off your list. Don't think of BRAF with these appendiceal mucinous neoplasms. Your differential, obviously mucosal hyperplasia or hyperplastic polyps, those can occur in the appendix. Serrated lesions do occur within the appendix as well. That might be a hint for going through your challenge cases. as well as tubulovillous and villous adenomas. You can look at metastatic mucinous carcinoma, so this would be where we'd want to rule out GYN origin. And obviously ruptured appendiceal diverticula. Diverticula can occur even in the absence of all this mucin and whatnot. So you want to make sure that it isn't just a diverticula that you're dealing with that was maybe irritated. Okay, treatment. So again, we can have excision with clear margins. So we go back to the argument of an appendectomy versus right hemicolectomy. And some people want to take out a lot more stuff. Okay, and obviously as we go more towards our high-grade lesions, towards our invasive adenocarcinomas, this is where you would start getting more aggressive with surgery. And they'll also consider doing adjuvant intraperitoneal or systemic chemotherapy. But again, the prognosis for these is relatively good. When you're looking at your lamins, it's closer to 97%. Your high grade, it's closer to 67%. And as with most things, your prognosis is related to your grade of the tumor. So that's your mucinous neoplasm. I will fix that spelling mistake because it's very glaring to me now. And we'll get that back to you. So now we're going to spend the bulk of our time, as we did last week, on colon. This is case 3. So anything that kind of strikes you at low power?
Those black spots.
These areas?
Yeah, and the more prominent.
Okay. Yeah, so these are really prominent. And this is super pink. I'm really attached to colors. And it looks kind of like a polyp. Like it looks like it's this round, maybe undulating thing that you can imagine was on the surface of somebody's colon and they just plucked it off while they were doing a colonoscopy. So okay, if we zoom in, what we can see is that
Lymphoid aggregate.
yeah, these are lymphoid follicles, so that's okay. We don't know exactly where we are in the colon, so this is fine, right? These aren't scary at all. And we could look at all of them, but we won't.
The small bubble.
This is colon.
Wait, why are these villi?
Why are these villi?
You see those they seem villous. Oh, this is polyp. Maybe that's why.
It's a polyp. So polyps can have a large variety of architecture, and they can be confusing. And what we start seeing here is that, first off, it's very edematous. Okay, well, that can be an artifact, so maybe we shouldn't pay too much attention to that, except for it's kind of within the entire lesion. If I back up a little bit, even when we're starting to go into the deeper portions of the polyp, we still see there's that edema. There's a little more pink, so maybe there's some collagen deposition. And we see a lot of these guys. So they're very red. They have disco ball or headphone nuclei.
Eosinophils.
These are eosinophils, right? And you know, if we were in derm, we would be having a moment right now because, oh my gosh, this is a lot of eosinophils. But yeah, a lot of eosinophils. We have a lot of lymphocytes as well, the little marker stamps, because that's what they always kind of look like. And some plasma cells, right? Wherever you have lymphocytes, you usually have plasma cells. And you can always tell them by the eccentric nucleus. You can't really make out the perinuclear Hoff, but they do have it. Okay. And that's pretty much it. So, to our somewhat unfortunate senior resident who just walked in, we have a colon polyp. Very edematous. Lots of inflammatory cells.
Inflammatory polyp.
Yeah, but you know, the senior's supposed to All right. But yeah, this is an inflammatory polyp. So, okay, so this was my one real moment in lecture where it's like, this is not neoplastic. But you see them all the time, and as a first year, I saw these and they freaked me out. So I thought it would be a good idea to put them in the polypoid section. But yeah, this is a inflammatory polyp that can happen at any age. They are relatively common. I should have put that above, but they can occur in any age, and they tend to occur between the ages of 10 to 30, especially in patients with history of IBD. They do occur in 10 to 20% of patients with ulcerative colitis. That's what that means. And they can occur in elderly patients with peripheral vascular disease as well. So you'll get GI biopsies all the time from someone who's in their 60s or 70s, and this was kind of the only thing they saw, and that's okay. I put in here a little bit about the theory, but pretty much what this means is we don't really know what causes them. And they can occur anywhere in the colon. If the patient has Crohn's disease, they usually tend to occur at the ileocecal junction. And they are flesh-colored or mucosal-colored, and sessile lesions less than 3 centimeters. So I don't know about you, but 3 centimeter polyp in the colon still is pretty big. But these can be really small, or up to a little over an inch in size. They can be pedunculated, which means they have a stalk. Filiform, which means they'll have like these finger-like projections or papillary projections. And pretty much what you see is regular colonic mucosa that might be irritated and inflamed, and you're going to have this very expansile lamina propria. You could have crypt abscesses, you could have cryptitis, because again, this is inflammation, so it's not unreasonable to think that you would have these things associated with it. You can have surface erosion, which again would be accompanied by granulation tissue. And because there's erosion and granulation tissue and all this inflammatory stuff and it's edematous, you can get some crypt distortion, okay? The cells themselves will look very reactive. So you'll see, like, you may see prominent nucleoli, but the chromatin should be clear. You shouldn't have hyperchromatic cells. And you want to be aware of this because your stromal cells can mimic sarcoma, okay? Remember, fibroblasts can look very ugly sometimes, and so can endothelial cells when they get irritated and inflamed as well. So you just want to keep that in your differential. And even though it says inflammatory polyp, the case that I found was actually inflammatory fibroid polyp. Just because I had that little bit of extra collagen within the stroma, so it had this slightly background fibrotic look. But does it really matter? No, you could just leave it at inflammatory polyp and that would be okay. Love it. Yes, I do love it. Okay. This is why I liked WebEx, but I was asked to try Zoom, so we're trying Zoom.
That's why you have a gift.
Yeah, okay. And there's also prolapse-associated polyps. So prolapse-associated polyps usually happen in the rectum, and you get like this smooth muscle streaming up towards the surface. So you could see how prolapse and the fibroid polyps might look kind of similar. Here what we're showing is just you have some cryptitis going on here, all these little ants, these neutrophils, and here this is a much more prolific inflammatory response. So it can range from this to the case that we had where it looked relatively paucicellular and edematous. Whole bunch of negative stains because you want to make sure it's not other things. And your molecular usually diploid, so no need to do molecular. Usually you can tell what these are on H&E anyway. Your differential would be things like juvenile polyp. Juvenile polyps have extremely dilated crypts, and they can, if they're associated with juvenile polyposis syndrome, you'd want to think about things like, is there adenomatous change, as well as pyogenic granuloma, and this would be related more to when you have granulation tissue, surface erosion, and again, pyogenic granuloma being a relatively old name, We typically use lobular capillary hemangioma now, but they mean the same thing. Treatment, polypectomy and control of bleeding, well, usually they do this at the time of C-scope. If they can't remove the entire polyp, then they usually put a tattoo in the area so that they can go back. If it's related to inflammatory bowel disease, so Crohn's or ulcerative colitis, then they'd want to give them immunomodulators to just try and tap down that response and not aggravate that condition more. And again, these are completely benign, but they can be scary looking.
What does usually diploid means?
So diploid means normal.
Okay.
Yeah. Fancy way of saying normal.
Okay.
So basically, don't waste your time and money and the patient's time and money doing molecular tests because they don't help you. And then what these are showing is here we have intact epithelium and then it's gone, so you have erosion. And same thing here, no epithelium, but we have lots of new blood vessels. And this is probably a lot of neutrophils. It's hard to tell because I make the picture smaller, but this is granulation tissue, just to kind of show you what that should look like. Oh, okay, well, that's interesting. This went out of order, so we'll fix that too. It's been a day. So obviously you know the next case is hyperplastic polyps, so I'm expecting everybody to get everything right about those. All right. Do you want to take that?
All right.
Sorry, I'm a little tethered.
It's fine. They took my chair away. That's okay.
Oh, no, it's right there.
Yeah. Still took it away. Okay, so this is the biopsy. Which side of the side?
No,
No?
we get told colon.
Oh, okay. Well, usually
Yes.
they give you a side, and that helps because
It does.
with the other side.
The piece on the left-hand side of this slide is clear. The middle piece is not clear.
Sorry. Oh,
No, I had to figure this out myself too.
okay.
So that's the tip you guys get for coming to the actual lecture, is that you know that which section is actually the best to look at.
Well, so looking at this, so this was probably like, they call that polyp or something, they probably saw something. And so looking at this, you notice this looks kind of weird, right? I mean, there's still mucin, so it's not dysplastic or anything. But it does have this kind of sawtooth-like, it looks like it's kind of dilated here.
Yep.
No, I'm holding it for you.
Oh, yeah. My backup mics and all that.
It's like a sawtooth-like, but it's not really dilated, but doesn't go all the way to the bottom. It's very superficial, and that's the differential for, as we learned today, from SSA, sessile-serrated adenoma. So yeah, and usually I think this is on the left side, if I get my left side.
Yeah,
and
usually.
SSA is on the right side. Yeah.
Yeah, but they don't always listen to the rules.
Not always, but if given the choice, it's something that will sometimes help, because sometimes this is actually a really good biopsy because you can see the sort of the basement membrane here very nicely. Sometimes you don't, and
yes.
it's like, and you're just like, okay, I wonder, and then the left and right can help you hedge a little, but over here it's just, I would say this is hyperplastic polyp because it does not go all the way to the bottom. It doesn't like bottom out like a boot or inverted T or L or whatever you call it.
Excellent, and not just because you saw the slide ahead of time.
Well, that too. It would be very embarrassing if I called this an SSA after seeing that slide.
Well, in all fairness, like 2 hours ago, the slides were in the right order, so I don't know what happened. But it happened, so that's okay. We'll fix it. But yes, these are the most common polyps. So 75 to 90% of what you see is hyperplastic polyp. And they are, that's what that means. So the next line means they can occur at any age, but they are more common in patients older than 50 years. Generally, they're asymptomatic, right? People don't know that there's all this stuff growing in their colon. A lot of risk factors and associations. They're more or less up there for your curiosity, but again, these things are so common that you just see them all the time. They are predominantly in the rectum. About 90% of them will occur there, and they're often multiple. And these are relatively small, so 1 to 5 millimeters compared to what we saw previously with inflammatory polyp being less than 3 centimeters. It's actually rare to have a hyperplastic polyp that's larger than 1 centimeter. However, if they're in the right colon, they're not as irritated, there's more room for them to grow, so they tend to be a little larger. They will have mucosal folds, and they tend to have a polypoid appearance, which is great since we call them a polyp. And as was pointed out, they often have this dilated surface, so it kind of gives the appearance of like an inverted triangle or a cup shape as well. They are serrated lesions. However, there are variants that are less serrated, which we have on the next slide. So again, these variants have no clinical relevance, so it's more or less for our curiosity to say, oh, this is a hyperplastic polyp, goblet cell rich, or microvesicular, or mucin poor. But what you should note is with the goblet cell rich polyps in particular, they really don't have the serration. So what you're looking for is that dilation of the luminal surface. That often is all that you get with those. Whereas you can see with the mucin poor hyperplastic polyps I have on this page, you can still see that serrated architecture. Even though it's not super prominent, it is still there. And it's the next slide, I think, that has, the goblet cell rich. So hopefully you can appreciate on the right-hand side how they just really look dilated. They look shallow and almost scooped out, but they don't look serrated particularly. Actually, that bottom one looks somewhat serrated, and that actually, in the ones that I've seen in sign out and the ones that will come in practice, don't have serrations. They have that dilation. So your Ki-67 is about the only useful stain, and it's going to show increased mitotic activity at the base of your crypts only. So that's important if you were worried about, is this dysplastic at all? They do tend to harbor BRAF and KRAS mutations, as well as they may have DNA hypermethylation. But again, you do not have to do molecular studies to call a hyperplastic polyp a hyperplastic polyp. They're differential. Honestly, the closest thing would be your sessile serrated adenomas or sessile serrated polyps. But when you're looking at things like your goblet cell rich hyperplastic polyp, normal colonic mucosa comes in the mix, and you also need to think about mucosal prolapse, since that can also have a serrated appearance to it. Excision or biopsy is often done at the time of C-scope, and when they're doing the C-scope, these actually look identical to adenomas, so they, don't ever give your endoscopist a hard time, because they really can't tell, is this a TA versus an HP? So you just take what they give you, and hopefully they tell you what side of the colon things come from always, so that there's inflammation, and you can figure out if that's appropriate or not. Again, these are spontaneous. They're relatively benign. If they're associated with things like your familial disorders, which again we have the huge list of associations, then those can be associated with increased risk of malignancy. Case 5.
I should do.
It's not just me, okay.
Right.
T-Mobile. No, okay.
So I can identify the colonic mucosa and the crypts.
Beautiful, yes. Colonic mucosa, we have lots of crypts. We have zoom just kind of falling down into everything.
These are serrations too.
Yes, wonderful serrations.
But they are in the top half.
They're in the top half, yes.
Oh, there we go.
That's different.
So it's in the basal, the serrations are in the basal half of the epithelium.
Yeah.
So this is serrated. Is
Okay.
it?
So what we're looking for really is basal dilation that's more than the superficial crypt.
Oh, I didn't know
Technically.
about that criteria.
Yes. So if it looks like a stovepipe all the way down, but it's dilated, that doesn't count. It really has to have that lateral expansion, which this does.
Yeah. Okay, let's see more.
Let's look at the other piece. Be good, Pat.
Oh.
Look at that one.
Yeah. So you see how that one's super dilated, but you look at the
Yeah.
base and it's not. So you have to be careful with that
Okay.
because there are other polyps that just have dilation.
So this one
Those ones
is.
are better.
Those ones are better. So, but that's why they say like the Italian boot, where it's like super skinny up top and then it gets wide at the bottom because you have the heel and the toe of the boot. And I think that's it.
That's it.
Okay, so yes, this is a sessile serrated adenoma. So 3 to 9% of your polyps and about a quarter of your serrated polyps will be these. There is increased incidence with age. Thank you. And we do see them more in women than men. As most of our polyps, they are asymptomatic, and the risk factors, as with most of these polyps, smoking, obesity, alcohol, diets high in fat and meat, so things that really are going to work the colon extra hard. These tend to occur in the right side of the colon, but again, the polyps don't exactly read the books, so if you're in like the sigmoid colon or something and you see something that's definitely a sessile serrated adenoma or sessile serrated polyp, you can still call that, okay? On gross examination, like up top, I have what they would see on a C-scope, and you can see that it's slightly polypoid, but it's really flat and there's not a lot going on. And when it says adherent mucosal cap, it basically looks like relatively nondescript mucosa over top of this lesion. On the bottom, what I'm showing is more basal dilatation and serrated lesions and wonderful embedding because it's like perfect embedding. So you do have that serrated epithelium with the lateral spread of the basal crypts, so that's your Italian boot shape. There will be a lot of mucin associated with this, so very much similar to hyperplastic polyps. So you can see why hyperplastic polyp versus an SSA, that can sometimes be a difficult differential to get around. But these are mature cells, and what's interesting is that you will still see the mature mucinous goblet cells within the basal crypts. Okay, normally your basal crypts are extremely blue, they're hyperchromatic, you don't see too much mucin in there, but in SSAs you will, so that is a different appearance. They can have low-grade or high-grade dysplasia, so if that is present, you would have to comment on that, and it would be something like sessile serrated adenoma with low-grade dysplasia, or low-grade dysplasia rising in sessile serrated adenoma, etc., etc. Because it is mucin, your positive stains would include things like MUC5AC. You can also see TTF1, which is a somewhat unusual stain to use in the GI tract if you're not suspicious for either small cell or metastasis. What you can see is loss of HES1 or loss of some of your mismatch repair genes, and that would be in areas of dysplasia for your mismatch repair genes, and HES1, I believe, would be in your differential against adenocarcinoma. Again, you don't have to do stains typically for these lesions to call them, and you don't have to do molecular, even though there's molecular. So you often will harbor your V600E BRAF mutation, which is your most common BRAF mutation, period. There can also be some CIMP high activity, as well as microsatellite instability because of that CIMP activity. So where before we had seen no BRAF mutation, this has no KRAS mutation. KRAS mutations being relatively common in your colonic adenocarcinomas. So your differential includes your HP versus traditional serrated adenomas. Again, excision, which is normally completed at C-scope, is the treatment of choice. If they are very large, which in this instance would be greater than 1 centimeter or have high-grade dysplasia, you would want to treat them as a high-risk adenoma, so like a TA with high-grade dysplasia or TVA. These are a precursor lesion, so 15% of patients with SSAs will develop adenomas with high-grade dysplasia or colorectal carcinoma. So that's why when we say SSA on a report, that patient is going to get increased screening, which every few years it changes what they will do for screening. But it's important to note the difference between saying this is definitely an HP versus this is an SSA. You will change how the patient is followed. There is also high risk of developing colorectal carcinoma if you have a large lesion, which makes sense. If you have a large lesion, there's more likely to be faster growth, so maybe it's harboring more high-grade dysplasia. So these are all things that you just kind of want to keep in the back of your mind. And on the right, we have the arrow is pointing towards an Italian boot, and the arrowhead, maybe some basal crypt dilation. Doesn't look too descript. And on the bottom, just more of that Italian boot. So again, that lateral expansion along the muscularis mucosae, and that's important because, again, your hyperplastic polyp will be dilated above that. Your juvenile polyps will just be dilated in general. But sessile serrated adenoma should be dilated at the basal crypts with lateral expansion. Case 6.
This one kind of fell apart.
A little bit.
Alright, so we have some sort of epithelium. And then this looks like, figure out where are we here. Do I see pruner glands? Not quite.
And I do want to point out that I like this case, A, because it showed what I wanted it to show really well, and 2, this is often how you receive GI biopsies, where they're extremely poorly oriented because they're really small pieces,
Yes.
and they fall apart.
Well, it looks like you're in the small intestine. Because of the surface epithelium. Correct me if I'm wrong.
I'll let you go. You're glossing over the lesion, though. What's the lesion?
Well, it's very inflamed.
Okay. It's very blue, right? I think everyone can see that this is really blue.
Is dysplasia here? I don't see. Yeah, it looks like it's dysplasia.
This is dysplasia, yeah.
Oh, is this the TA you're talking about?
This is a TA!
Okay. Sorry, I got confused by this little piece.
That's
here.
okay.
Yeah.
It looks like small intestine. That's why I'm like, correct me
This
if
was
I'm
such a
wrong.
beautiful example of TA. I was like, no, we're
See, that's why it's
using
important
it.
to know where this thing is from. You will not be told this is a random polyp or random biopsy from somewhere.
Well, you could. You could. Stranger
you-
things have happened.
Then you have to have a very long talk with the GI people.
Perhaps. Perhaps. Hey, for putting this together in like 3.5, 4 hours, I'm doing good. So, all right. But yes, this is a tubular adenoma. So again, adults older than 50, males more than females. So again, a little different from what we've seen in other things. 25% males and 15% of females will have these at time of their colonoscopy, which will occur hopefully when they're 50 years old, but there's plenty of people that, delay colonoscopies until something else happens. If they're small, which means less than 1 centimeter, they're usually asymptomatic. And if they're large, they start to bleed. They can cause obstructive symptoms. And that's when people go, oh, something's wrong. I should probably get that checked. Okay, so sites you're looking at for the colon, the left colon as well as the rectum are most common, but they can also be spontaneous and associated with familial adenomatous polyposis. And you can also see right-sided TAs associated with Lynch syndrome. That's not to say that if you have a right-sided tubular adenoma, you have Lynch syndrome, and a left-sided TA that you have FAP, but it's something to keep in the back of your mind with these things. They can be sessile, which means flat without a stalk, or they can be pedunculated. They are often erythematous or redder than the surrounding mucosa. If they are friable or ulcerated or villous, which again means like those finger-like projections, or very large, that's when you start to get concerned that there's maybe some high-grade dysplasia going on. So on the top, what you can appreciate is that they are extremely blue compared to the surrounding mucosa. On the bottom, again, towards the top of the bottom picture, you can see, again, they're extremely blue, almost like if they were at the basal, the base of the crypts, but they're at the surface, so it's like this reverse maturation or loss of maturation. And then what else do they have? There's some inflammation, looks like some pan cell change. Anyway, we're moving on. Okay, so by definition, these have to have less than 25% villous component. If they have more than that, then you're looking at a tubulovillous adenoma or villous adenoma. The colonic mucosa itself will again have this abrupt transition where you see normal mucosa, then all of a sudden you're in the lesional area. They must have at least low-grade dysplasia, and low-grade dysplasia for tubular adenomas is elongated hyperchromatic nuclei with pseudostratification. So pretty much what happens is you get the elongation of the nuclei, they lose their mucin, so you have this very blue area, and the surrounding epithelium will look relatively pink next to it, or clear. For your high-grade dysplasia, you start to see more architectural changes, so maybe some cribiform pattern, which for the most part we don't like anywhere. Luminal necrosis, you can have prominent nucleoli, so if inconspicuous means you can't really see them at 10 or 20x, conspicuous means you can see them, and you're not hunting for them. The chromatin will still be relatively vesicular or open, and there will be loss of polarity. So again, instead of having your nuclei at the base of the cell and having apical mucin, you're going to see those cells drifting towards the surface. And yeah, so mucin depletion, we already talked about that. You can also see a lot of different metaplasia. Osseous, squamous, as well as Panna cell metaplasia are the most common. Again, Panna cells are only really considered important metaplasia once you're past the mid-transverse colon. Okay, they're totally normal to see in the right colon and the beginning of the transverse colon. So, but if you're seeing that in the sigmoid colon, that's unusual. All right, again, a feature of chronicity. And what they like to do is they like to have pseudo-invasion with tubular adenomas. So what this means is that the glands will get pushed down and they'll look like they're maybe angulated or something like that, but you're not going to see desmoplasia around them. In fact, you're going to have regular lamina propria or hemosiderin, because if they bleed around them. So everything around the glands will appear completely benign, which is what the bottom picture is showing. The top picture is kind of, looks like we have maybe some inflammation as well as loss of polarity. There is some pseudostratification. Looks like they're pointing out some lymphocytes maybe. Hard to tell. They're so clear when I'm looking at them on a single computer screen. Positive stains. So BCL2 is going to be diffuse in pretty much every tubular adenoma. and CAA will be positive only in your areas of dysplasia. P53 should be negative. Again, you don't usually have to do stains for these, and even though there's all this section on molecular findings, you also really don't have to do molecular. But if you did, KRAS mutations, TP53, APC, beta-catenin, and there's actually different types of mutations associated with tubular adenoma. So type 1 tend to be basically not villous at all, and they have less mutations. And the type 2 are a little more villous, but again, they don't go above that 25%, and they're going to have higher incidence of TP53 mutations, KRAS mutations, as well as MGMT loss. Okay? Your differential includes inflammatory polyp, a TVA, again, that's more or less your architectural definition, as well as invasive adenocarcinoma. And the biopsy that they do at colonoscopy is potentially curative, which is great, but if they're large or difficult to reach, they'll tattoo them, and depending on the size and extent of them, how much dysplasia, they might either elect to do an endoscopic mucosal resection or a segmental colectomy. And then prognosis, there's almost a 10% risk of progression to invasive adenocarcinoma with TAs. So again, with saying that a patient has a tubular adenoma, that does change their screening to some degree, and also does portend its own risks associated with that. What your slides are showing on the top is Panacell metaplasia. Hopefully by this point in the GI series, you guys know that I love showing Panacell metaplasia. It's just like the prettiest thing ever, with those really red granules that are towards the apical surface. And on the bottom, what we have is squamous metaplasia. So that's your tubular adenoma. This is case 7.
Ooh, mushrooms.
Mushrooms.
Well, it's a pretty big biopsy.
I know, isn't it nice? Probably because they did a resection on this.
Yeah, okay. Well, this is where the fun part is. So let's take a look. It's not really invasive.
That's good.
Yep, that's a good start.
I like that.
Yep.
We're always happy for a patient when we get to say not invasive.
See some mild dysplasia here, kind of like in a TA, but this is more like a villus architecture. Well, maybe tubulovillus
Okay.
adenoma. It's not quite there yet for like a villus adenoma. I haven't seen much of those, but I feel like this is not enough.
Yeah.
It has to be very fillery. Not a better
Fillery. Very finger-like.
Like.
Whereas this, it almost looks like it's arboring or like a
Yeah.
maze where you could
Yeah.
almost trace all the areas.
And I don't think there's any lesion here really. This is just in. Ooh, look at that, it's so pretty. But it's just in like cross section really, tangential. And there's nothing here. So I think that's the lesion. So is it TVA?
This is a TVA.
Yay.
Yes. So I love this look because you get to see the normal mucosa, which is over here.
Nice and pretty.
It's nice and pretty, and then you see the hyper intense blue purpleness beside it. That's really scary. And so you learn to hone your eye to these kind of things. So even at low power, you pick that out and you go, whoa, that's not normal. It's a mushroom. Yeah, they often are mushroom-oid. Or
Mycoid.
mycoid, there you go. All right. So our tubular villus adenoma, this occurs in adults, average age of 62, which again makes sense because when do we start screening? 50 years old. Males more than females at about 1.5 to 1. These are generally asymptomatic, but they can present with rectal bleeding. These occur in predominantly the distal colorectum, but you can see them in the proximal colon as well. And it's about a 60-40 split or 70-30. And these are relatively, well, from my experience, like I've usually seen more, either they're definitely sessile and polypoid. Sessile and polypoid always seem to go together, I think, or they're pedunculated and either polypoid or villous. And again, villous or finger-like projections, or what's another term? Filiform. All those things mean almost like ferns, very long and wavy. Yes.
And also in terms of grossing these things, if it's a large specimen, I think if I remember correctly, you really just want to focus on the base part. You don't really.
That is correct. Yeah. So if you have this huge mushrooming lesion, you want to ensure that you have taken sections, like all the sections of the stalk, the resection margin. If it's small, usually you can get away with like trisecting it, but you have to make sure that the resection margin is completely submitted, because if there's invasive components, that's where it's going to be. It's not going to be on the surface of this thing, and two, it can be really difficult to assess for invasion. So you want to give them where they actually took it off so that they can determine what to do next with the patient. You don't want people just going for a right hemicolectomy or left hemicolectomy just for, funsies. Okay, so whereas our TA had less than 25% villus component, this must have more than 25% villus component. And there's differential between tubulovillus and villus adenoma. But again, you're probably going to see more tubulovillus adenomas than villus adenomas. That really doesn't change things between them. You will have these very elongated papillary projections, and papillary projection means that you have a fibrovascular core, so there should be vessels in there. There should be some sort of connective tissue as well. And again, like tubular adenomas, these must have at least low-grade dysplasia, and the description is exactly the same as tubulovillus adenoma for low-grade dysplasia. For high-grade dysplasia, what you can start seeing is what we call glandular budding and tufting, where it's kind of like these outpouchings or branchings of the glands. You may or may not see ectopic crypt foci, which again just kind of looks like you have these crypts that are in places that don't quite make sense. As all high-grade dysplasia, you start seeing an increased nuclear cytoplasmic ratio. The nuclei have stopped becoming elongated and start rounding out. So you get these really plump, really bizarre looking nuclei. The chromatin can still be relatively open. And again, you're going to have that loss of polarity. If you do have mitotic figures, do expect to see some atypical mitotic figures. So whether it's, a snowflake or a smiley face or something, it just doesn't look like anything that should be in any of your textbooks unless that textbook is showing you atypical mitotic figures. You can see metaplasia, and again, this can be any sort of metaplasia, but squamous is the one that really likes to associate with tubulovillus adenoma, and it often likes to be in direct contact with the adenomatous glands. So then you start wondering, oh, am I dealing with collision tumor? It gets really fun if you're in the rectum, because it's like, where exactly in the rectum am I? Am I close to the anal verge? Is this actually like collision tumor? So again, this is where knowing your endoscopist, having a good relationship, and them putting on the requisition where they're taking things is really important. Positive stains, okay, so it's in the colon, CK20, it's mucinous, CDX2, beta-catenin, P53, so again, looking at mutations that's likely to harbor, okay. Negative stains would be CK7, but 5% are positive, so not super helpful. Mutations are often KRAS, but you can also see APC, SMAD4, TP53 mutations, and if this is Lynch syndrome, you'll have loss of your MMRs. So you'll be looking at doing potentially IHC and all that for the mismatch repair proteins. Your differential includes things like, is this just a TA? Is it adenoma like adenocarcinoma? Because of course there's a variant that looks like adenoma, and as well as your serrated adenomas. Treatment, if it's small enough, they might be able to excise it on colonoscopy. And again, if it's not too big or too much high-grade dysplasia, like if it's more low-grade dysplasia, they might be able to do that mucosal resection, or they might have to elect for a segmental colectomy for high-grade dysplasia and large size. This is an advanced precursor, so whereas our tubular adenoma was a precursor lesion, this is an advanced precursor lesion. So instead of a 10% risk of progression to adenocarcinoma, this has a 17% risk of progression, or a 1.77 times risk of malignant transformation. Your pictures are just showing more of your pleomorphism. That looks more like low-grade dysplasia to me. High-grade dysplasia starts looking a little more pink because you have the plumping of the cells. But these look more elongated, but you can see those really nice fibrovascular cores. Okay, tubulovillous adenoma, colon. So this is case 8.
More colon.
Oh. Ooh. What do we have? So I see these crypts and they kind of look compressed.
Okay.
Like there's luminal narrowing or something.
Okay, so the crypts look maybe compressed, maybe angulated.
Yeah. Over here maybe.
Are they respecting each other's spaces?
No, they seem crowded
Yeah.
and branched.
There's just no rhyme or reason to the arrangement here. They're just kind of going wherever.
Mm-hmm. Okay.
Yeah, eventually that goes up.
Alright. Okay, wow. It's hyperchromatic. The cells are hyperchromatic. We don't.
Yes,
I
very
don't see
hyperchromatic.
Nuclei are kind of extending all throughout.
Loss of polarity.
Loss of polarity, yes.
Yeah. Do you have any goblet cells?
I don't see any. Is this her?
No.
It's
So, like, the mucin honestly is, like, goblet cells are one of your best indicators of something is very wrong with this. When you have colonic lesions that are extremely blue, that should clue you in that, hey, there's something not right here, because goblet cells are very happy in the colon, right? We like our colon to have lots of mucus and be well lubricated. It makes life happy. And yeah, so when we're seeing all these cells that are expanding up towards the luminal surface every which way you go, and none of the crypts are aligned in a way that makes sense, are we maybe at least in dysplasia?
Yeah, for sure.
Yeah, for sure. I love it.
Yes, this is not normal for sure.
This is not normal. That's exactly right. Okay. So what do you want to say about this, or do you want to look at more stuff?
Let's see. I mean, the adenocarcinoma that I've seen was more poorly differentiated. So
Excellent point. This is not poorly differentiated. This is
Yeah.
pretty well differentiated.
Yeah, you see kind of, you still see crypts. It's not like sheet of cells, so.
Yeah. Do we see desmoplasia?
Yeah, this pink stuff. Is this what it is?
So desmoplasia is usually like a gray blue.
I think there was some earlier if it was back.
Yeah. This is where I usually tell you guys, okay, zoom out.
How do I zoom out?
You all like to be at 40x all the time.
So if you look sort of
I'd zoom out a little more.
Here?
Zoom out a bit more.
No, this is relatively normal. So you need
Do
to
you
zoom
wanna-
out even more.
Let's try it. Let's hunt for the desmoplasia.
If it's there.
Yeah.
So here's a fun fact. You don't always have to have it. Oh, E, you're doing the same thing. Back up. You can appreciate desmoplasia at lower power, mid to lower power.
But I'm just saying, well, my eyes are getting old, as well. But
This
see,
is
this-
desmoplasia.
this sort of actually.
But
this is
you
probably
lose it
best.
when you go too high.
Yeah,
So
it's kinda like
you see how
this
it's
sort of
blue-gray?
bluish. Yeah, and it kind of seeps through.
And what are these?
These are what are you mean? Sorry, I zoomed in. This thing.
Say it.
These are cells. These are the.
No, that's not what I was
Oh,
pointing
no.
at. These big pink things.
Oh, these things.
What are these? They're arteries, right? These are big vessels. And what do we have underneath them?
Mm-hmm.
Cells.
The
Epithelial cells.
The
Yes.
dysplastic epithelial cells, right? So when we're looking at that and we're going, okay, you're supposed to be at the surface. Our vessels are supposed to be happy underneath.
So there's.
And see how there's
This
fat
is
here.
invasion.
Look at this. There's
It's fat. It's in the fat. I try really hard to give you a great section of things where it's like, okay, I don't want you to guess too much. I mean, sometimes I do, but I try to limit the guess what I'm thinking.
Where's the muscularis? It's like
Yes, where is the muscularis?
it looks like it went completely through, like it just completely ate through it or something. I don't know.
So
Maybe the thing
I'm.
is not.
Oh, here.
Oh.
It's here. What about here?
It's gone.
Yeah.
It's eaten.
Yeah.
So the cancer is eaten through it.
Yeah.
The cancer is what?
It's eaten through it. Because there's no real surface up here, right?
Yeah.
This is all ulcerated.
Mm-hmm.
So
This is what,
sometimes.
stage 2?
So it's in the fat.
Oh, it's
So
in the fat, so it's stage
that
3.
would be stage 3 because
Yeah.
it's through the.
Where is it in the fat? Well, is this considered
Maybe.
fat? Maybe. I guess so.
So wait,
So if it's in the fat, then that's stage 3. Okay, staging is in your handout.
It's
It's-
you
yeah,
go
it
from
has
the
to be
outside
through the
in,
propria.
like backwards. Yeah.
Because it's like 2A if it's like into it, but not halfway through, and then it's like 2B, and then yeah, I always look it up. And why? Because they also change things. So
Yeah.
yeah.
But Dr. Willis will make sure you're like.
Yes,
You know
that
this.
is true, and there's nothing wrong with that. But I do honestly look it up every single time. So this is my point to everyone on the line that it's always okay to look at books. It's always okay to ask questions, because at least from my very minimal experience, there's always someone who knows more than me, and I really like hearing from all of them. Yeah, so it's just the arrow, the curved arrow up. Yeah,
Okay.
no touchy.
There.
Okay. And can you click back in the screen? Thanks, because I can't control it. All right. So yeah, this is your colorectal adenocarcinoma, which is great because I spelled that correctly since we've been having spelling problems today. And in the U.S. alone, we have 150 to 160,000 new cases every year. It is the third leading cause of death, third leading cause of cancer death in the U.S. Okay, so not overall, but if you're looking at just cancers, we also just call this colorectal carcinoma or CRC. Again, adults increases with age, men more than women, about 2 to 1. So all those things make sense because it's in keeping with pretty much everything we've been seeing tonight. So the symptoms associated with this are anemia and hematochezia, diarrhea or constipation depending on what the lesion's doing, and weight loss. Risk factors, whole bunch of risk factors. A lot of them either associated, again, with smoking, or do you have a diet that's high in fat, low in fiber, or do you have one of these other syndromes? And again, there's a lot of them listed there, so that you guys can kind of be aware that there's a lot of things that can cause this. Last week when we touched on our inflammatory bowel disease, remember that those patients are at increased risk of developing colorectal adenocarcinoma. And again, this can occur anywhere within the colon, But over the years, at least in the US, there's been a shift towards right-sided disease as well as younger age of onset, okay? And maybe that's just because we have better screening now, maybe because we're aware of more of these disorders, but that has been the general shift. These are mass lesions that may or may not have central ulceration as well as raised borders, as you can see on the top right. I have a beautiful schematic from ExpertPath. As you guys know, I absolutely love their pictures. They are fantastic. So what we see there is a very large fungating type lesion that's really taken over the entire circumference of the colon there. And on the inset is, what do they call that? I lost the words.
Barium.
Barium, thank you, a barium scan, which yes, they do by enema. And what that's showing you is that apple core sign. So what you're seeing is really the space that's left that the cancer hasn't eaten up. And the empty space, or the apple area, is actually occupied by the tumor. Microsatellite unstable high are often the very large bulky tumors, and those are often in your older females. So it's not perfect, but again, if you had this huge right-sided cecal mass that's in, a 75-year-old woman, you might anticipate her being MSI high. Microscopically, you may or may not see desmoplasia, so you see why we harped on that a little bit, because you don't always see it, which is somewhat counterintuitive for an invasive lesion. For our MSI high tumors, again, right colon is more common. They are either well or poorly differentiated. You should not have moderate differentiation with an MSI high, okay? They are relatively well circumscribed, and they may have this Crohn-like or really inflamed reaction. You don't see dirty necrosis. If you do, it should be extremely focal, not diffuse throughout the lesion. And they have this very heterogeneous appearance. So what that means is, like, some areas will be very well differentiated, and then you'll get to other areas that are very poorly differentiated, and it kind of goes back and forth. You will have these tumor infiltrating lymphocytes, or TILs, and it's basically just you have increased lymphocytes that percolate throughout the lesion itself. There are variants, of course there's variants, right? So I put on there the mucinous colorectal adenocarcinoma. There can be focal mucinous differentiation. You can have signet ring differentiation. You can have the adenoma-like adenocarcinoma. So lots of things to keep in mind, but the mucinous and signet ring would probably be the big ones to keep in the back of your mind. You might also find the precursor lesion. So you might find that TVA or TA on your sections beside the invasive carcinoma. So that's far more common in the sporadic setting, but sometimes it's really appealing to see, like, where you have your normal mucosa, and then you have the serrated lesion, the precursor lesion, then you have the invasion. So it's really nice for learning the scope of these lesions as well. When you have a microsatellite stable lesion, these tend to be the moderately differentiated adenocarcinomas. They are infiltrative, and you can see tumor budding as well with these. They don't have the tumor infiltrating lymphocytes. They don't have that Crohn's-like reaction, but they will have lots of that dirty necrosis. So that's why I put the picture of the dirty necrosis on the top right. So you see that we have all the pink necrotic areas and lots of neutrophils as well. Okay, so
What does tumor budding look like microscopically?
So tumor budding, again, it's like you're going to have your crypts and then these areas that aren't quite glandular, but they're definitely tumor. It literally looks like it's budding. Do I have a picture of that? I don't know. I don't know that the desmoplasia really shows it well. So if these pictures don't have it, I probably don't have one that actually shows it. But pretty much it'll be like, again, areas with tumor that doesn't quite make sense. Like it's definitely not a crypt that's involved. And it's not like the presence of tumor deposits and satellite nodules. Those are reportable like in your synoptic report and stuff like that, and they affect prognosis. Tumor budding is not one of those things. So it's important to recognize, but I don't have a picture, so that makes it hard to show you, like this is what it is. But we'll try and find something at some point. So send me an email or Google. Not everything has to come from me, right? And then that way we can put something up somewhere. Your positive stains, colon, CK20, CDX2, CK7. So you notice how I'm repeating all these stains over and over again, and they're found in the same lesions over and over again. So that kind of should clue you in that your morphology kind of tells you what things are more than the stains, at least for these particular lesions. For colorectal adenocarcinoma, depending on the school of thought and where you're practicing, certain places will be like you must do mismatch repair immunohistochemistry plus minus microsatellite instability testing on all cancers, cancers that have high grade or cancers are poorly differentiated. So there's a whole batch of literature and practices that will dictate what people do. At our institution, we do more mismatch repair and MSI testing, but again, this does vary widely. It's not tightly regulated. For molecular findings, again, your KRAS and BRAF are the big mutations to be aware of. If a patient has a KRAS mutation, you don't have to waste time looking for BRAF because it won't be there, and vice versa. If they have BRAF, they're more likely to have SIMP high or high methylation. Again, your differential would be adenoma with pseudoinvasion or metastatic adenocarcinoma, right? This could be adenocarcinoma from another site, whether it's GI related or not. For these, they do excision, so usually at least segmental colectomy with or without neoadjuvant chemoradiation, and then more adjuvant chemo, and 5-fluorouracil is the chemo of choice for that. They may or may not do PD-L1 treatment if they're MSI high, and they may or may not do radiation. So there's a lot of different things that they can do with colorectal adenocarcinoma. Your overall prognosis depends on depth of invasion and lymph node status, as with most tumors. And if you have BRAF mutations as well as SIMP high, those patients tend to have the lowest survival. And then obviously we have desmoplasia, and then the heterogeneity is just kind of showing you on the top left we have more, not exactly well differentiated, but more better differentiation, and then towards the bottom right it's more poorly differentiated. And I don't have it here either. Okay, so I put on this slide to kind of show the difference between well-differentiated, moderately differentiated, and poorly differentiated, as well as some of the morphologies associated with whether it's mucinous, signet ring, or MSI high, because again, remember, MSI high has its own set of difficulties. And I'm not really seeing tumor budding.
It's okay.
Either. Yeah. That's unfortunate. And I honestly didn't think to look for a picture of that, because it's a good question. Okay. We have 2 more lesions, so we are going to blast through these very quickly. I believe in you guys. Number 9.
Biopsy.
Biopsy. Woo!
Whoa, whoa. Okay.
We're back in DermPath.
Skin. Skin. Okay, nice keratinized layers, nice granular layer. Looks like a polyp of some sort.
Okay. I agree, these lesions are polypoid.
Well, I don't see any overt dysplasia. Well, maybe, I don't know, these cells look kind of big going up.
Is that keratosis?
No, that's
No,
granular layer.
That's regular carrot. No,
And that's
nuclear.
orthokeratosis.
Yeah. Well, it looks like these cells are still kind of big going up there. It's like some sort of condyloma or something.
Yeah, exactly, some kind of condyloma. This is condyloma acuminatum. Okay, not everything has to be high-grade dysplasia. And I think this was like one of the only examples that I could find in the GI system. So, so this is like a cute little condyloma acuminatum, or anogenital wart. So it all falls under anal intraepithelial neoplasia. So you can see all the different names over the years, and there's our condyloma acuminatum, but people will still use that, as well as anogenital wart. These can occur at any age, but they predominantly occur in adults, and there has been increasing incidence noted of these. They occur in men more than women, and they're human papillomavirus or HPV related. So what's important to note is that serotypes 16 and 18 are associated with high-grade AIN as well as squamous cell carcinoma, whereas 6 and 11 are more associated with condyloma, which just means, like, are you looking at the low-grade or high-grade dysplasia? Often these are asymptomatic, but the patients might have this eczematous rash, it might be itchy, and over time it might even start to bleed. For sites, if you're looking at upper anal canal, these tend to be covered in colonic mucosa, and they're often missed because, again, the patients don't really have symptoms. And if we're looking at transitional zone, again, that would be your squamocolumnar junction or your anal rectal junction. And often the patients will have multiple of these, and there's a whole bunch of different appearances. They can either just be like a white patch, they could be a red macule or papule. Most commonly we see things that are like a flesh-colored papillomatous lesion or cauliflower-like. And again, if you're looking at something that's within the anal canal, it's most likely to be flat. And the giant condyloma or Buschke-Lowenstein tumor is just kind of something to keep in the back of your mind. And they are absolutely massive, massive lesions. Okay, so what do we have in pictures? So the top one is showing, looks like AIN, at least 2, maybe 3. It looks like it's going pretty much the whole way up. We have dyskeratosis as pointed out by the blue arrow, and I think our open arrows are just kind of showing us loss of polarity from base to surface epithelium. The bottom picture is showing you what I feel E was likely looking for, which is the coilocytes. So what you can see is that they have that clearing around the nuclei. The nuclei should be enlarged, which I guess we're going to recapitulate all this on the next page, but it's nice when you can see the picture. And they tend to have this raisonoid appearance where they're kind of wrinkled or crenellated. Okay. Did I miss anything? Okay, so pretty much the difference between AIN and condyloma is it neoplasia confined to the mucosa, or is it a papillary squamous proliferation that's related to HPV infection? So for something that's completely covered in colonic mucosa, you wouldn't want to call that condyloma acuminatum. Just a little bit of definition. But again, it's not wrong to use the AIN for both areas. They tend to have a very high nuclear to cytoplasmic ratio, and the nuclei, as we've been talking about, will be enlarged, hyperchromatic. that raisonoid appearance. You may have the coilocytic halo. You can just see reactive atypia though, as well as binucleation. All these things are signs of reactivity as well as the HPV infection. You will see loss of maturation between the basal and superficial layers. That's kind of the definition of what's going on. And you can see mitotic figures above the basal layer, and they may be atypical, particularly if you're looking at high-grade dysplasia within the lesion. Your adjacent mucosa, so the normal mucosa that's next to the lesion, is going to be acanthotic or thickened, and it's still going to have that papillary architecture, but with normal maturation. You may or may not see parakeratosis, which, as we remember from our germ path, parakeratosis tends to clue us in that there's something in the area. You can see dyskeratosis, and the other important thing to note is that any mitotic activity in the adjacent normal squamous mucosa is only going to be in those basal layers. Okay, and then this point I have about the low-grade, high-grade dysplasia, just as you know, that can involve the anal glands. Somewhat similar to how when we have cervical intraepithelial neoplasia, that can also involve the endocervical glands. So similar thought process. What your pictures are showing you on top is more of the coilocytes with the loss of maturation in the basal layers, so that looks more like a CIN2, or sorry, AIN2 in the GYN frame of mind. Your bottom right picture is showing you, again, coilocytes as well as atypical mitotic activity. It is within the basal layer, but that is an atypical mitotic figure. More coilocytes, because I figure I have never seen enough coilocytes, because every time I think, a nuclei is raisonoid enough, it's not big enough, or it's big enough, but then it's not raisonoid. So I need to look at a lot of pictures, and I figure if even one other person needs to look at a lot of pictures of coilocytes, then I'm doing them a service. And then the other picture is showing, looks like parakeratosis. So that's probably adjacent to the lesional tissue. That's what it looks like, at least. So your positive stains, this is one that really, if you're going, am I looking at AIN1 versus 2 or 2 versus 3, that's when you do a P16 stain. You don't do them when you're like, this is definitely AIN1 or this is definitely AIN3, because what do you do if the result doesn't work with that? Because in theory, AIN1 should be negative and your AIN3s are positive, but lesions don't always read the books, and they don't always listen. So you don't want results that you can't easily explain away. So really only do it if you're looking at, is it 2, because that's where it helps you. If you do an HPV stain, it should be nuclear, but you can also do an HPV in situ hybridization. Oh, having difficulty speaking. In situ hybridization, which is far more sensitive than the IHC, but a lot of places will start with the IHC. You don't have to jump to ISH right away. And the molecular pathways between AIN and squamous cell carcinoma of the anal genital region have the same HPV-associated oncogenes, which is your E5, 6, 7, that inactivate your tumor suppressors. So I don't have it on here, but I do have it on the next case. But your E5 is believed to deal with your growth factor receptors. E6 inactivates P53, which we know would be bad, and E7 inactivates retinoblastoma 1, which we know is also really bad. Your differential is pretty much, is this full-out carcinoma? Did we just undercall it? Your treatment for these, they can either do wide local excision, which is usually the favored approach. They can do things like imiquimod, which is immunomodulator. They can do podophyllotoxin, and you can also try to be preventative by having people undergo HPV vaccination. This is a precursor lesion to the anal squamous cell carcinoma, so you want to be aware of that. And your pictures. So on the bottom, that's really the more interesting part. Up top is just kind of showing you more dyskeratosis. But on the bottom, if you do run a P16, this diffuse positivity, that is what you're looking for to call P16 positive. Okay, so that's the precursor lesion. So this is case 10, our last case.
More biopsy fragments, ugly looking cells. Is there invasion? I think there is. It's kind of like off kilter, but like these pieces are not very useful, but I think this piece is nice because you have these sort of places going down here that's detached.
Can you go up top, since I don't have a mouse, and where it says more on the right and it's orange? So that we can see, because people are in the chat, so click on chat, please. Even from afar, yes, even from afar it's something bad. And yes, evasive adeno.
Yes.
Love it. Okay, so
Invasive squamous.
invasive squamous. Okay, can we go further?
Well, let's see. I mean, you can still kind of tell it's like, you know, there's some spongiosis. But you can still tell they're kind of look like, it's not, I don't think it's keratinizing first. I don't.
Okay, maybe go back to that first piece that you looked at.
Maybe, let's see, where is it? Yeah, I mean, you can't really, if this piece looks a lot worse and that piece looked a lot better, you can sort of tell that they may have been squamous cells. I mean, it's still some sort of squamous cells, so I'd say moderately differentiated.
Okay.
Moderately to poorly differentiated.
Other thoughts?
To me, these two cells look like lymphocytes. So.
It looks like lymphocytes. Okay, that's not a bad thought either. They have a lot of cytoplasm. And okay, maybe we got most of the way there because there was a question of, is it even keratinizing?
Not really see anything definitive.
Okay. Well, for me, I go, the surface, you can tell that's squamous epithelium. So I'm like, okay, that's good. But the bulk of the lesion, I'm going, I don't know what you are. So when I go, I don't know what you are just by looking at you, you're poorly differentiated. Now, in anal squamous cell carcinoma, they like to get real fancy, and they don't just stick with everyone else. It's like, oh, this is well differentiated, poorly differentiated. They're like, oh, this is a cloacogenic carcinoma or basaloid carcinoma. So they're saying the same thing. So with squamous cell carcinomas, we look at, okay, what's the differentiation? Are they keratinizing or not keratinizing? This is a non-keratinizing squamous cell carcinoma, which in most other areas of the body, we would just say that. Invasive, non-keratinizing, squamous cell carcinoma, poorly differentiated. Here, you would say something like basaloid carcinoma or the cloacogenic carcinoma, which is an older term, but people do still use it. So that's what this is. So a lot scarier than that very bland condyloma. I was really hoping to get like an AIN 2 or 3, but there wasn't any in the database, so I apologize for that. Okay, so thankfully this is relatively uncommon. It's only 1 to 3% of GI carcinomas, but it's pretty much all the anal tumors you're going to see are going to be squamous cell carcinoma. Yeah, there's that cloacogenic carcinoma or basaloid variant. This tends to occur in adults between 40 and 60 years old, men less than women. Okay, so female predominant lesion. This is also HPV related, so we're not going to go over all of that. The only other thing to note are your other high-risk types are 31, 33, 35, but 16 and 18 are pretty much the ones that they're going to ask about. If you do testing like for like a lot of pap testing and whatnot where they do those other serotypes, it'll just say like other high-risk types. So your risk factors, so, you know, of course they give like a whole schwack of them. Smoking's on there, not surprising. Patients who have had sexually transmitted disease, they do point in things like anal intercourse, and then there's this controversial debate about whether chronic injury associated with inflammation and repeated injuries to the area, so like things like perianal Crohn's disease. I suppose there would even be maybe an argument about ulcerative colitis, but I think where they were trying to go with this was more like the fistula formation and fissures and things that just keep getting irritated and opened up. But again, that is highly debatable. HPV is the thing to know for this, HPV. So these are painful masses. So where our condyloma and AIN were relatively painless, these are painful. They tend to ulcerate. Patients will complain of hematochezia. They can have fistula formation as well as tenesmus. And these can occur either above or below the dentate line. So again, if you go back to the previous week's lecture, I had a schematic from ExpertPath on there about the dentate line and your internal external hemorrhoids. So it's the exact same area that's talking about where this can occur. And the appearance, as a lot of these lesions that we've seen tonight, can be variable. So they can be ulcerated or just kind of indurated and erythematous. They can be these huge masses that are fungating or polypoid, or you might just see flat mucosa with patchy erythema. So you want, where I really think about flat mucosa, patchy erythema, no definite mass, that is often like when you're looking at post-radiation therapy. So they've tried to get rid of the lesion as much as they can before surgery. And the reason they do that is because it makes it easier to resect, and sometimes it can even take patients who were previously unresectable to a resectable point. So that's why they'll do radiation ahead of time. In your pictures, it looks like the arrowhead on top is pointing to like a lone coilocyte maybe, but you also have the invasion and that loss of maturation with, well, reverse maturation really, with that open arrow on the bottom. And then the bottom picture is showing you some incredibly well-differentiated squamous cell carcinoma with those beautiful whirling keratin pearls. I don't think I've ever seen keratin pearls that nice in carcinoma, but that is beautiful. So microscopically, when you're looking at well-differentiated, again, well-differentiated we associate with well-developed squamous nests of any size really, and they may or may not be keratinized, but they often are, and they often have those keratin pearls. And as we saw in our case, you can sometimes see those intracellular bridges, which are your desmosomes, those little spiky projections, which is all your keratinocytes holding hands so that they don't fall apart. And you often have mitotic activity. When you have a basaloid appearance, which is what our case was, the cells become smaller and they are still nested, but the cytoplasm becomes a lot less. You can see some palisading, but it won't be super prominent palisading, so I suppose I should put that in there, that it's a very subtle finding. You can see central necrosis, and you may or may not see keratinization with the basaloid appearance, but typically you won't. That's kind of how, in some other areas, how we would define basaloid, but you can have cases where there is some focal keratinization. So don't be worried too much if you're seeing that with the overall pattern being basaloid. If it's just a small area of basaloid differentiation, then you can probably just comment on that. Of course, there's other patterns. Transitional cells, so does it look like urothelium, where you'd have like more elongated cells with those longitudinal folds. You can have mucin production, and you can have these very large polygonal cells with pale cytoplasm encompassing your entire tumor, so that can also add to some of the fun. And verrucous carcinoma is actually really an extremely well differentiated squamous cell carcinoma that always has this pushing border. So if you're looking at something wondering if it's a verrucous carcinoma, but it looks like it has an infiltrative border, you need to think again. But these honestly look so benign that you almost gloss over them, except for the varicated appearance. So we're showing obviously our basaloid appearance with focal keratinization on the top, and on the bottom we have rather significant nuclear pleomorphism, maybe with some coilocytic change as well, but kind of hard to tell. Okay, so stains for this. P63, you can do CK56, which CK56 tends to stain squamous cell carcinoma no matter where it is. If they're basaloid, you'll see positivity for CAA, EMA, pancytokeratin, as well as P63. So P63 should be positive regardless of if it's more conventional type squamous cell carcinoma or basaloid. Again, it's the HPV-associated oncogenes, so we're not going to go over that again. And your differential would be, is this actually a colorectal adeno? Is it a basal cell carcinoma, because those can occur in the anal region, or is this a neuroendocrine tumor? And again, when you have those small to medium-sized round blue cells that maybe aren't super bizarre, you'd want to think about neuroendocrine tumors, which that's why in the negative stains I have things like synaptophysin and chromogranin, because that would help you figure that out. So treatment for these, they do adjuvant chemoradiation, same as they do for AIN, or can do for AIN, I guess. Or no, wait, scratch that. They don't do that. They do excision for that. But for this, they'll treat first with chemoradiation, and then they'll resect, and then they might do targeted therapy after the fact. Unfortunately, a lot of these carcinomas are already at late stage where the patients will have metastases to at least regional lymph nodes, if not distal metastasis. So a lot of the patients are really high stage by the time they are diagnosed. And squamous cell carcinomas that are present within the anal canal and not at the anal margin or anal verge will have a later presentation as well. And again, because they're not going to be as symptomatic, so unfortunately, like, those patients tend to do worse. For stains, up top we have CK56. So remember, CK56 is a good stain for squamous cell pretty much anywhere in the body. It can be positive. It's not always, but it's not a bad one to have. And that P63 should be positive whether you're looking at just your regular squamous cell or your basaloid. So that's one to keep in your back pocket. Okay, and that's what we have for this week. So there are 20 challenge cases from this lecture. And some of them are things that we talked about, some of them are not, but I just thought some of them were really cool lesions for you guys to look at. Do keep in mind that some of these are extremely difficult, so do your best, but don't worry if you don't get everything on the first try, because I definitely don't get everything on the first try either. And can we check the chat box again? I see it going off. Yay, thanks guys. This was a lot of fun, and I actually really like having that chat option. That's great. I need to figure out the sound though, because we have no sound, so it'd be nice for you guys just to be able to say what you're thinking, because I know it can be frustrating if you're trying to chat and then you're like, oh, I have this point, and then we move on, or somebody else says something and you forget what you're typing. But yeah, if you guys like this video, and you know, even with all our horsing around and whatnot, please hit like, If you aren't subscribed to us, please hit subscribe so you know when we have new content out. You guys will notice in your handout from this week that there are a lot of extras in the back in particular. So the last couple pages were actually from the first polyp lecture that I gave our residents, which was, you know, back in the times when we could all sit at a multi-headed scope and not have to worry about masks and all that. But I just thought some of them were really great references. All the little boxes with typing on the right hand sides, those are all me. So if you're like, hey Kara, that doesn't make sense, just let me know. And again, if you have any comments, things you'd like to see, things you don't want to ever see again, please let us know either in the comments or you can send me a message on Twitter. And we will see you next week with a new series on slide review.